All right. Good afternoon, everybody. Thank you again for dialing into our Ask the Experts colon cancer awareness featuring the Blue Hat Foundation. All lines will be muted for the remainder of the presentation. We will have a question and answer portion of the presentation at the end, where we encourage you to type your questions in for our presenters today. March is Colorectal Cancer Awareness Month, a time dedicated to raising awareness about prevention and early detection. Colorectal cancer is one of the most common cancers, but it's also one of the most preventable when caught early. Regular screenings can detect precancerous polyps before they turn into cancer and identify cancer at an early stage when treatment is most effective. Today's webinar is an opportunity to learn more about colorectal health, understanding your screening options, and hear from experts about steps you can take to protect yourself and your loved ones. If you're age 45 or older or have a family history, screening is an important conversation to have with your healthcare provider. We are joined today by Kim Angelo and Candace Henley. Kim Angelo is a healthcare market development manager with Exact Sciences. In this role, she's focused on reducing the number of individuals who remain unscreened for colorectal cancer. Kim has a family history of colorectal cancer that includes 2 first-degree relatives diagnosed before age 50. As a result, she's been a vocal advocate for CRC screening for many years and is honored to combine this personal passion with her work at Exact Sciences. Kim lives in Chicago and supports the CRC screening needs of organizations, healthcare providers, and average risk patients across the Midwest. Candace Henley is the founder and chief surviving officer of the Blue Hat Foundation. Her journey into advocacy began while she was actually at the Chicago Transit Authority as a bus operator, navigating the complexities of the healthcare system during a life-changing colorectal cancer diagnosis. Her work focuses on clinical invisibility and the socioeconomic barriers that prevent minority communities from accessing life-saving screenings. Beyond her community-based outreach, she is an adjunct lecturer at Northwestern University, specializing in anti-racism and clinical investigation, and serves as director of equity and partnerships for the Global Colon Cancer Association. Candace is an internationally recognized voice, leading the shift in the healthcare narrative from institutional permission to community sovereignty. Thank you for being with us today, Kim. Thank you for being with us, Candace. And I'm going to turn it over, I believe, to Kim first.
Thank you, Dakota. And a giant thank you to the CTA Wellness team. So Jess and Liv, thank you for the invitation, not only to join you alongside Candace at the Health Jamboree last fall, but also today as we talk about something that's very close to Candace and my hearts, and that is colorectal cancer screening. Before I start sharing my screen, I know Dakota kindly introduced me, but I'd like to share a little bit more about my personal connection to colorectal cancer before we kind of dive in. And I'm going to take you back 30 years. So in the early 90s, it was 1993. Picture a 17-year-old Kim at the time. I was a senior in high school, and my mom, who was 49, started having some abdominal pain that was quite severe, and went to the doctor, and they thought maybe she had an ulcer. And of course, I didn't know anything about ulcers or abdominal pain, being a carefree teenager. But pretty quickly, we realized that something very serious was going on. And she was diagnosed with colorectal cancer at age 49, had no previous family history. This was a time that was before there were any screening guidelines in place. So it was just before even colonoscopy was recommended for people as a preventive means for screening. And so really there was no opportunity to catch this disease state before it progressed. And she was diagnosed at stage 4. So that means the cancer had spread beyond the colon, distantly to other organs. And at that time, there was just not a lot that could be done. Yes, she had surgery. Yes, she had chemotherapy. But sadly, she lost her battle a year later. And really, as a result of that experience as a teenager, I have been passionate about screening for colon cancer since I was a teen. And that's why today I'm so honored to be here next to Candace to discuss why screening matters, and to hopefully encourage either you or someone that you care about to take the next step and get this done. So with that being said, I will share my screen. So give me one moment, please, to pull that up. Okay. And I can't see any people when I'm sharing my screen. Could someone just verbally tell me they can see this?
You can see it.
Yep.
Wonderful, thank you. Okay, so we are going to take an overview of colorectal cancer, also referred to as CRC, and colorectal cancer screening today. So Candace mentioned this, this first statistics as we were talking just prior to the start of today, and that colorectal cancer is one of the leading causes of death. And I don't know if the average person knows that. This purple sentence is already outdated. Just recently, the announcement has been made that for people under age 50, colorectal cancer is the leading cause of cancer death. I think most folks would find that surprising. And over the course of a lifetime, about 1 in 25 people will be diagnosed with colorectal cancer. So if we think about, I did a little bit of research on how many people fit on a bus, right? On a bus, it looks like, you can correct me if I'm wrong, you're the experts here, about 53 people sitting and standing. So over the course of a lifetime, about 2 people on that bus will be diagnosed with colorectal cancer. So if we look at the incidence, it's the 3rd most common cancer across men and women. And the risk is only slightly higher in men. So women are not off the hook here. It's just a very slight difference. Everyone has a colon, and so everyone is at risk for developing colorectal cancer and needs to be screened. Okay. Colorectal cancer, it's often considered the most preventable, yet the least prevented cancer. And partly because people just don't like to screen for it. They don't look forward to doing the screening. Yet that screening has so much power because identifying colorectal cancer early or even as a polyp before it has a chance to develop into cancer results in treatable diagnoses. So that treatment is successful over 90% of the time when this type of cancer is diagnosed early. There's so much power in screening for this diagnosis. So if we talk about the colon and rectum, these are organs that are really important, but we probably don't think about them every day, right? So just to orient you to kind of where we're talking about. So the colon is also called the large intestine, and it is a tube. It's about 5 feet long total, kind of like an accordion, okay? It can stretch out. It reabsorbs water and salt from the food that we eat, and it stores waste. So that is the bright pink, as you see here. And the last about 6 inches of the colon is the rectum. So a cancer that occurs anywhere within the entire tube is called colorectal cancer. All right, just to make sure we're all on the same page there. What is colorectal cancer? It's in a simple definition, it's a growth of abnormal cells within the colon or rectum. And how does that happen? So most colorectal cancers just start as a growth that's also called a polyp on the interior lining of the colon or rectum. So just think of extra tissue growing interior on that lining. Most often polyps are like a small mushroom. It has a stalk and a little top, but sometimes polyps can also be flat and kind of hidden in the wall of the colon. And over time, some polyps change into cancer. Not every polyp changes into cancer. okay? But every cancer started as a polyp. So over time, if left unchecked, if screening didn't occur, for example, or this starts very early before an individual had met the age requirement for average risk screening, those cancer cells can grow over time. They can damage the tissue and spread to other parts of the body. So why does this happen? All right. So there are generally two ways to think about the causes of colorectal cancer, and this is really simplifying something that is quite complex. So bear with me. The first would be an inherited syndrome. Now, this is possible. It's something similar to, you may have heard of like Lynch syndrome. Lynch syndrome is a familial type of colorectal cancer. It's also associated with other cancers, and it's important, but it is very rare. So only about 5% of colorectal cancer cases are associated with a genetic syndrome. Okay, so that means 95% of colorectal cancer cases aren't. They just happen over time. They're what is called acquired gene mutations. Things change the genes over time. It could be the environment, it could be some type of exposure. There are a lot of things that are, considered possible triggers or things that lead to colorectal cancer, but there's no like one definition of something that definitely causes it. So knowing your risk factors is really important because some of them you can do something about, right? They're modifiable. So what can you modify? What can you change? Obviously, the type of food you eat is likely going to impact the health of your body and especially the health of your colon, because you think about, we talked about the job function of that colon is to reabsorb water, right? You're reabsorbing salt. If you're, talking about a part of the body that's absorbing things, we want to make sure the things that are going into that colon are healthy, right? So diet can impact your risk. Physical inactivity, we know that's a risk factor for many different types of diagnoses. Alcohol use, the same, right? We talk about moderation with alcohol use, and then maintaining a healthy body weight. And then what is not modifiable? Our personal or family history. Our health history is not modifiable. Sometimes we wish it was, it is not. Other things like your genes, your inherited syndromes, although rare, that's not modifiable. A diagnosis that increases your risk of colorectal cancer, like inflammatory bowel disease, that's not modifiable. And by inflammatory bowel disease, I'm not talking about IBS, irritable bowel syndrome. That's totally different. That does not increase your risk of colorectal cancer. But IBD, which is often including Crohn's disease or ulcerative colitis, those diagnoses increase an individual's risk of developing colorectal cancer. Our age, maybe that's something else we wish we could modify. We can't, right? As we age, our risk for developing different types of cancers and other health problems increase. And then our racial or ethnic backgrounds. People of color are at a higher risk of developing colorectal cancer and are often diagnosed at later stages. And one of the things that we can do to help change that is talking about it, right? Talking about it and encouraging screening. So we know we can impact developing cancer, and especially colorectal cancer, by being physically active, maintaining a healthy weight, eating well, and not smoking. Those are good life rules regardless. Now, recognizing symptoms, it's so important. It's paying attention to your body. It's being an engaged patient. That phrase of, no one's going to advocate for you except for you, right? Speaking up if you notice something. And when it comes to colorectal cancer, those symptoms could look like changes in bowel habits, feeling like you need to have a bowel movement that doesn't go away after you do, having rectal bleeding with bright red blood, or seeing blood in the stool, which may make it look very dark brown or even black. Other symptoms could include abdominal pain, weakness, feeling tired, or losing weight without trying. Now, it doesn't matter what your age is. If you're having any of those symptoms, go see your physician, go to the doctor, be an advocate for yourself. I don't care what the screening age recommendations are. If someone is feeling or noticing these symptoms or changes, they should speak to their physician. Now, when it comes to screening, this is something that is recommended to start for average risk people at age 45. Okay, this changed in 2021. The American Cancer Society and the United States Preventive Services Task Force reduced their age recommendation from 50 to 45 for screening for colorectal cancer. Why? Because more people under age 50 have been developing this diagnosis. So they want to catch additional cases before it's progressed. Simple as that. So average risk folks, the screening age begins at 45, and it's generally recommended to continue to age 75. For people over age 75, it's based on a physician conversation. Okay. And what does average risk mean? Average risk is most people. Okay. It's most people. So it's not people that have a history of colorectal cancer themselves, or they have a history of polyps. If they have a family history of colorectal cancer, you're not average risk. If you have a personal history of inflammatory bowel disease, as I was mentioning earlier, things like Crohn's disease or ulcerative colitis, this is not average risk. Any type of hereditary syndrome or history of radiation would not make you average risk. So if you haven't had any of those things, you are average risk. So again, most people fall into that average risk category, which means screening at age 45. It doesn't mean talking about it at age 45, thinking about it, and then screening at 50. You want to really take the power and screen as soon as you're eligible. So how can we do that? There are a number of different ways that are approved. The most common ways are highlighted here. So certainly everyone has heard of the visual exam, the colonoscopy. This is done as an outpatient procedure. It simply requires prep the day before. There's no food consumed, and then you're prepping to clean out that colon. And then it truly is a simple outpatient procedure. You are sedated, and it gives that visual exam of the colon. The really nice thing about the colonoscopy is that if it's completely clean, you're good for 10 years of screening. So unless something changes, you don't have to think about it again for 10 years. And if they find a polyp or something that needs to be removed, generally they can take it out at that time, okay, and look further into it. So that is a really nice feature of a colonoscopy. One of the challenges is it's some time off of work, and it does require that prep, and there's fear. And so what sometimes occurs is that people choose to do nothing rather than to get a colonoscopy. And that is not the answer. Okay. So there are options for non-invasive screening if you are, again, average risk. Okay. So what are those options? The FIT test here, the fecal immunochemical test, and the FOBT test, these are both two tests that have been around for a long time that are simply looking for blood in the stool, blood that you may not necessarily see. And it's just essentially swabbing the surface of the stool and putting it on a cardboard card and mailing it in. And then it's analyzed in the lab to see if there's blood. Okay. And then there's also another test called the Cologuard test. This is a test that's looking for blood and altered DNA that is shed from the lining of the stool, or pardon me, of the colon, and then captured in the stool as it's exited from the body. So this test, because it is more sensitive, it's looking at more than just the presence of blood. It's also looking for those DNA changes. It's good for 3 years. So if you screen today, you don't have to worry about it unless something changes until 3 years from now. Okay. For any of these stool-based tests on the left, if an individual received a positive test, the next step is that colonoscopy. Okay, so that is important to know. If a stool-based test tests positive, it doesn't automatically mean that you have colorectal cancer, but it does mean that you need a closer look at the colon, and so that colonoscopy is the next step. Okay. Back in 2023, new legislation went into effect that requires that follow-up colonoscopy after a positive stool-based test is considered part of the screening process. So that means there should not be an additional copay or cost out of pocket for that follow-up colonoscopy. Okay. So we talked about the fact that this is one of the leading causes of cancer death. And for people under age 50, it is the #1 cause of cancer death. Okay. We know that this is a cancer that's preventable and more treatable when it is caught early. And that is why we need to screen. I have 2 more pieces of information to share before bringing in Candace and highlighting her story. I really love sharing this slide because I think it's so important to see this cross section of the colon. Okay, and it really just, you can help visualize why screening on time matters. So if you're looking at here, we see that muscular tube, right? This is the colon kind of cross section, and it's so easy to see something that is a stage 0, like still a polyp, versus something that's stage 4 that is so large and has grown outside of the wall of the colon. It is night and day in the ability to just simply remove this and move on with life, right? Between the early stages and the later stages. And that highlights that why between for the need to screen. So many individuals don't have symptoms until the later stages. So again, this is why we screen. We talked about patients of color having more cases of colorectal cancer. This is real. And this is why we're also discussing it, highlighting it, providing that education so that everyone has that confidence to get screened. All right. One of the things that hasn't been addressed that I think is so important is this fact right here. The 75% of people have no family history. That 75% of people that have a colorectal cancer diagnosis have no family history. If you think it cannot happen to you because no one in your family has experienced this, it's wrong. This is something that's happening more and more, and to people at younger ages, people below age 50, regardless of family history. And that power is yours to act as soon as you're eligible to screen so that you are not one of these statistics. So before I move over to Candace, I chatted with Jess and Liv, and they allowed me to share. This is one way that you can get a non-invasive screening test. Always, I would suggest talking with your doctor. This is the ideal way to manage your health. You work hard to earn health benefits. I always use them myself, that the ones that I earn from my employment. I encourage you to be your health advocate and use your benefits as well. So this is one way to access the Cologuard test. That is the non-invasive test. It's a stool-based test. It comes in this box. I also have the box right behind me. It's quite nondescript. It's just a white box. This is a test that's shipped to a patient's home via UPS. And essentially it has a bucket and a bracket inside. The bracket sits on the porcelain rim of the toilet. The bucket sits inside of it. And the way it's completed is to just place that in the toilet and have a normal bowel movement. So there isn't prep, there isn't anything special to do. You just have a normal bowel movement. And then you do two things. There is the blood test component, the FIT component. It scrapes the surface of the stool and it goes into a tube with your name and a label on it. And then the second step is emptying a bottle of preservative over the stool sample. That preserves the DNA until it gets to the lab for processing. Okay. And it's a great option for average risk patients who prefer to screen non-invasively. Okay. This QR code on the left would allow you to order directly as an option. Again, I always recommend talk with your doctor. That's the best person to align with for your future health, your current health. And at this time, I'll stop sharing my slides and I'll invite Candace to join me.
Thank you. And thank you so much for your presentation. I always think that it's very important that if we're going to talk about something, we also have resources to go along with it, because so often people hear information or they hear something and then it's like, okay, so how do I do the next step or where do I go? So, us doing this hand in hand is a great opportunity to at least give basic information or frontline information rather, to have people have the conversation with their provider to see whether or not this is an opportunity that's that's good for them, or is it something else. So having information in hand for people to go to their primary care physician or provider is exactly why we do this. And for me, it's definitely something that I wished I had had. However, I was 35 when I was diagnosed, so this wouldn't have worked for me, but it still would have given, some information that we could have gotten started from or been able to understand what colon cancer was at the time. And that was in 2003 when I was diagnosed. And I was essentially pretty much dismissed for 6 months. I didn't meet the age criteria of being, and at the time the screening age was 50. I was 35. So I didn't meet the age criteria. And even if I was diagnosed now, I'm, at 45, I still would not have met, the age criteria of 45. So I fell through the cracks and assumed, and everyone assumed that I was having either a heart attack the first time, the second time when I went to the emergency room, or it was female related because I was anemic. And so not understanding, listening to my body is why I kept going back to the emergency room, but not understanding, and able to articulate, my opposition to what they were saying was difficult because it kind of matched up. I was a bus driver. I drove long hours. I was a mom, with 5 busy children. I was managing this household and all these things that just made sense, like, okay, stress is this, is that. And so, we can make the case for it, but in hindsight, when I think about the journey, I had the signs and symptoms and I ignored them because I did make the case that, I need to eat better. I need to drink more water. I need to do this. My third time to the emergency room is when I was finally found to have colon cancer, but it wasn't until after they had done a hysterectomy because they thought that my anemia was tied to me having endometriosis and fibroid tumors. And even after that surgery and had the blood transfusion, I felt better initially for a couple of months, but then it started tanking all over again. when they finally found out that I had colon cancer, it was to the surprise and amazement to everybody. They're like, "You're 35." And I'm like, "Well, yeah, I know, but what is it?" And I didn't know what it was. And it was just a time in your life when you're at the prime 35. I have achieved the goal of buying my daughters a house. I was working my job, that afforded this house. I was driving, for CTA, and I was, trying to give my kids the American dream, and to have that cut short because of a cancer diagnosis. Not being aware, not being prepared, not having information. And I lost a lot of friends because people thought that colon cancer was associated with HIV. And so that, along with everything else that I was experiencing, was like, I need to educate people about what I'm going through, but also what colon cancer is, because if I got it, who else can get it? And I was still on that journey of trying to educate myself so that I can educate family members and friends. Like, hey, listen, if this happened to me, this could happen to you. This is, this. And, but I could not express that because I didn't have the wherewithal. And, I know by now everybody's familiar with the phrase "one battle after another." Well, that was my journey. I was diagnosed. I couldn't stop. I couldn't drive the bus anymore because I wound up having my surgery, my large intestine removed, and a resection to my rectum. So I couldn't drive the bus anymore because I was now bowel incontinent. And I couldn't, of course, you can't resign. You can't quit your job. You can't get another job because you have to resign from that and then reapply for something else. Well, I had cancer. Who's going to rehire me to do something else? So the financial piece of it was hitting me hard. I lost my house. I lost my car. I lost my 401k because I was trying to keep the mortgage paid. I was trying to pay everything, but the journey was, the cancer journey was still going. And at 35, it's like everything stopped. And in that moment, mentally, I felt like I was being punished. I felt like I was going through a Job moment. And because I didn't know what happened. I was like, what is going on and why me? And I'm sure there are other cancer survivors that feel the same way. It's like, why me? And colon cancer is different than all the other cancers because it does impact your life differently. It does prevent you from doing some things. And so I wanted to make sure that once I got through this journey, I shared my story, because when I was going through this, there were no brown faces of a 35-year-old woman that survived or was talking about colon cancer. Nobody was talking about it because everybody that I read, they either died, from colon cancer, or they were older. So I was left to my own devices to navigate the waters of, what comes next? Who do I see? And once I left the hospital, I didn't have patient navigation. I didn't have social work. Now they have all of these things. I didn't have any of that. So I'm in between a rock and a hard place. I'm trying to figure out who I need to talk to. No one should have to go through that. And it's almost like when you talk to some doctors, they ask you, well, why didn't you do this? It's like, I don't have any familiarity with cancer. So why am I expected to know what to ask when this happens to me? And I think that's the problem that we're having in our healthcare system and with a lot of patients. We don't know what to ask when we go to the doctor. We know that we're having these symptoms, but we don't know what to ask. And that's why I do this, is because I want to say, let me tell you what to ask. Let us tell you, hey, if you're having blood in your stool, if you're having, you haven't had a bowel movement, if you're having gas, if you're having anemia, unexplained, all of these things don't make sense, and you're not trying to lose weight on purpose. These are questions that you need to take to your doctor. Why am I doing this? What is happening to me? And if you're not satisfied, to continue and press and ask that physician, I need you to find the why. And if they're unwilling to, then you need to find another doctor who is willing to listen to you. I wasn't listened to, and it almost cost me my life. I found out 11 years after my diagnosis that I had a family history of colon cancer, Lynch syndrome. So I always say family secrets kill families, because my aunt said that, yeah, it was your dad and two of his sisters that had colon cancer, but she didn't feel that it was her business to tell the family that this was something that they were diagnosed with post-autopsy. They never even knew they had it because they died of other complications. So we have to do better when we start talking about, issues in families, in our families, especially something that has a hereditary factor. Breast cancer is hereditary, colon cancer is hereditary, high blood pressure, mental health, and then all these other issues that go on in families. We're a family full of secret keepers. And so because we keep these secrets, we do not talk. We do not share this health information. And so that is what's going to wind up killing our children and grandchildren, because we're not having these discussions. We're not making our children and grandchildren aware that this is something that's happening and this is something that you need to be aware of. Have you, if you experience this, talk to your doctor. So I come back and I share my story, not simply, because I want to get it out there, but because I want other people that look like me, other people that that are going through it, other people that have family members, that have friends that are being diagnosed and newly diagnosed, to know that they have somebody out here that's advocating for them, that's talking about it, and is like, hey, you know what? If you're not getting the support and service that you need, I'm here. I'm an advocate. I'm here to advocate. That's what the Blue Hat Foundation is for. When I was trying to find information, I took this back to my church, and we started Blue Hat Bow Tie Sunday, because I was like, how do we make people aware as fast as possible and as much as possible? And it's in the church. We stopped dressing up for the church. So for church. So we did Blue Hat Bow Tie Sunday. We asked people to dress in beautiful blue hats and bow ties. And it turned into a fashion statement where people were just dressing up in everything, blue fingernails, blue shoes. And it was amazing. But what it did was it became education through participation. And the more we did it, the more we got people that came back to us and said, because of this information you shared with us, I shared it with a coworker, I shared it with a family member, they got screened and they got tested early, and it was found. So my hope for this webinar and any other future works that we do is that we are able to catch someone in that space, that is sitting on the cusp of wanting to get tested, but not sure. Or someone that has been tested, they found that they had colon cancer, but they don't know what else to do. Or someone that has a family member or loved one, to think about the Blue Hat Foundation, to think about screening services like Cologuard and other tests, but also to think about going to your doctor if you have symptoms. Don't let fear kill you, because fear is the one thing that's going to keep you from getting tested. And I always tell people, don't fear the test, fear the disease. The prep, that's the easy part. The disease is the hard part. And so with that, I will stop and I'll ask if there's any questions and ask him to join us back on the screen. And thank you all so much.
All right, so we'll go ahead and, like Hannah said, we'll open up to any questions you might have. Feel free to type them in the chat, and I will go ahead and read those over to our amazing presenters.
And Ken, thank you so much for sharing, about the Cologuard, because that's so important. I think a lot of people, they see the box, but they don't really know what it does.
So we do have a question here, Candace. Did you change your diet?
So I didn't have a bad diet. So I was preparing for my first bodybuilding contest. And so I was eating chicken, fish, and turkey. So I was eating healthy prior to that, but because I had a family history, my dad was diagnosed with colon cancer. So it turned out that I had a genetic link to colon cancer, because my dad was 42 when he died. So, but he was diagnosed with stage 4 colon cancer and post-autopsy. So I should have been screened in my 20s versus finding out that I had a cancer in 35. So I didn't have to change my diet at the time of my diagnosis. Now my diet now, after cancer, I had to change my diet drastically, because I can no longer eat fruits and vegetables because I don't have a large intestine. I can't process it. And it, not to be too grotesque, but it just goes right through me. So in order for me to eat food like that, I have to have a diet that's high in starch and carbohydrates, because it kind of acts as a braking mechanism for my my new system now, like bread and pasta and things like that. And so it kind of slows things down, so that if I do have, vegetables, which is very rare, or they're overcooked so that I'm not experiencing the pain and cramping that causes, then it slows it down. So I've had to learn how to eat, and that's something that dietitians, unfortunately, they don't know how to create a diet for people like me who don't have a large intestine. So I hope that was helpful.
Thank you, Candace. She said yes. Wow, thank you. Anybody else or any other questions, either for Candace or for Kim? Just a couple minutes here. And then Candace and Kim, just wanted to let you know that there was a comment in the chat that just says, "Thank you both for your transparency."
It's my pleasure. Thank you. Thank you. It's an honor to do so. And I can leave my information. If anybody's, didn't want to talk on screen but want to reach out later, they can reach me at Candace and I'll spell my name CANDACE at bluehatbowtie.org. And if they want to reach out to Kim, I'm sure Kim can share her information if they have any questions about Cologuard. Or is that allowed? I want to make sure.
I'll put my email in the chat as well for anyone.
Okay.
All right. Well, it seems like we don't have any more questions there, so we'll give Kim a chance to put her email address in the box there. Thank you all for that amazing presentation. I know that it is scary to kind of leap into the unknown as it comes to diagnoses. I know that with any even chronic conditions, getting screened for those, it can be a little nerve-wracking, especially if you do have a family history, because it's that big what if, right? But hopefully today that what we can all take away is that it is important. We can't, I always like to say that no matter what type of wellness journey we're on, we can't know where we're going unless we know where we're at. So let's make sure that we are doing our parts to practice wellness in all of its forms. If you have any other questions for us, Kim and Candace put their emails in the chat. Or you can email wellness@transitchicago.com. Take a look for everything else we've got going on and the other seminars that we have scheduled in our lineup as well. This is now going to conclude our presentation. Once again, Kim, Candace, thank you so much for all the information and your time today. And I hope you all have a wonderful rest of your day.
Thank you. You too. Thank you so much.
Thank you. It's an honor to be here.
All right, well, take care, everybody.